Dr. Rajiv will tell us more about how combination treatment can help us in getting better success in treatment for DME. Thank you, Dr. Rajiv.
Thanks, Chatra. It's a pleasure being in AIOS in this IC. Next couple of minutes, I'll be more sharing some evidence. What is the combination intravitreal therapy, steroid and anti-VEGF, how feasible and how successful these are. So Unni had shown this, that the DRCRnet protocol I did tell us that early and consistent effects are seen nearly about 49%. And then you have all these four categories. Approximately about 40 to 50% of center involving DME have variable poor response to intravitreal anti-VEGF agents. And all the clinical studies have also tried looking at what are the predictors of response. There are many of them. And now we also know a lot of biomarkers on OCT, as Dr. Atul was rightly mentioning. There are a lot of other features which you look, the morphological features. And all of them, or many of them, they predict poor response to anti-VEGF. This was one of our study where we tried looking at vitreous cytokines. So we did the vitreous reflux, what comes out after giving anti-VEGF. We analyzed about 28 cytokines. And we looked into PDR, DME and no diabetic retinopathy. And what we all know, for probably proliferative diabetic retinopathy, VEGF is very important. It was very high. And even in DME it was high as compared to no diabetic retinopathy. But if you see PDR, it was nearly 2.5 times more as compared to no diabetic retinopathy. But if you look at other cytokines, they were very, very high. Many of them are inflammatory cytokines, especially in DME, and IL-1B, IL-1RA, IL-6, 7, 8, all of them were raised in diabetic macular edema. So intravitreal anti-VEGF are the first line definitely in center involving DME, but there are many non-VEGF mediators in center involving DME we know, and there are again good evidence which suggest that there is a role of intravitreal steroids in center involving DME which show a poor response to anti-VEGF. So this is definitely known. Lot of literature is there on that. Let's look into what happens when we inject steroid versus anti-VEGF, the vitreous pharmacokinetics. So you can see there is a big burst. So it's nearly 10 to the power 5 to 6 times you get dexamethasone molecules the moment you inject. And this burst continues for nearly about 60 days. That's what clinically we see, that probably about third month the response of steroid starts reducing. If you give anti-VEGF, again there is a big burst of anti-VEGF molecules. Now does it really make sense giving both together? No, because again one must realize that even steroids have got an anti-VEGF effect. So it will also block the VEGF, and now you are giving two molecules. It's something like they both compete to the same receptor. So do you really want to add both and give? So can we combine steroid and anti-VEGF, and is there any evidence for that? There are evidences. So people have tried looking at giving both together. They've also tried looking at, can we give it alternately? Give 1 month steroid, then change to anti-VEGF, then change to steroid. Let's see what the evidence tells. So both together, this was one of the earliest study which was done with bevacizumab and dex implant together. This was a 1-year study. And they found that definitely at the end of 1 year, both the groups where you gave combination versus alone bevacizumab, there was no difference as far as visual outcome is concerned. Yes, those who had steroids combination, they had better OCT outcomes. That's what this study talks. Then there was this DRCRnet protocol U. The problem was this was only a 6-month study. However, at 6 months, they also found that there is no difference, the same what they found in Avastin, the initial studies. Here also they found the same. There is no difference in vision, but had better OCT reductions as far as combination is concerned. And more recently, there is another study with ILIA. So they tried looking at, can we combine ILIA and dex implant? And they found at 6 months, again a short-term study, there was no difference as far as vision is concerned, and OCT reductions as compared to combination ILIA plus steroid versus ILIA, they are same. There is no difference as far as OCT outcome is concerned. And these were all prospective studies. One was a retrospective study, but we know the gold standard or the highest level of evidence are these meta-analysis. There has been one meta-analysis which tried looking at combination of steroid and anti-VEGF and DME and outcome at 1 year. So these are called as forest plots, and if you have this diamond, the black color diamond, so if it is towards the right side, it favors anti-VEGF plus steroid. If it's on the left side, it favors anti-VEGF. But if it crosses the line, that means both are same. So if you look at visual outcomes, you see that there is no difference if you give anti-VEGF or anti-VEGF plus steroids. Even you look at the central subfield macular thickness, there is no difference. This is at 1 year. They also tried looking at the side effects, and definitely you see if you give combination, more of cataract, more of raised IOP. So today the evidence doesn't suggest that we should combine both. Again, many times we will also, when we combine and give, we really don't know which one worked to reduce the edema at that stage. Can we have this strategy? This is again one of the studies which I came through when it's a nice study done, a prospective study where they alternated one group with anti-VEGF, one started with corticosteroid, and then they changed in between. And you see here again, they found that visual outcome and OCT outcome both were better if you are giving only anti-VEGF alone. Alternate group, the outcomes as far as vision, outcome as far as macular thickness was not that great. So probably combining is not a great idea as far as diabetic macular edema is concerned, both in terms of vision, OCT and overall outcome of the patient. Thank you very much. Any questions? I'll be happy.
Yeah, very well summarized, Rajiv. I think we always push for combination, but now from what you're saying, evidence-wise, it says that there is no, benefit at all. But then how do you, I mean, I don't know about the evidence that they've seen, but clinically we have seen that sometimes, at least the chronic edemas,
It will work similar with when you switch only to steroids.
Steroids.
See what happens when you have given both, you really don't know which
has worked. Exactly.
So rather than giving one extra thing, you switch to steroid.
So what do you do in practice? How do you switch, and then when do you come back? If you're alternating, when do you
I don't alternate.
Okay.
So once I switch, I continue with that.
Okay. Until that stops responding.
Yes. Absolutely
true. Rajiv, what do you do if there's center involving diabetic macular edema and there are areas of succinate rings in the macular?
Definitely laser.
So we should highlight that also.
Yeah. Off late.
Because we are speaking too much on anti-VEGFs.
Correct.
Like ophthalmology, retina has become anti-VEGF. So we have to talk about laser. Focal laser has a definite role.
Definitely.
And is excellent results. So if you got a non-center involving diabetic macular edema and they can on a 90D or a indirect, if you're good in your indirect, you will actually see the thickening of the retina in the paracentral area. If you see that thickening or you see succinate rings, the succinate rings, the ideal place to laser is a light burn, Esperance grade 1 in the center of the succinate ring. You find excellent results, you will cut down the number of anti-VEGFs. So anti-VEGF is not the kind of the answer for macular edema, because each anti-VEGF, actually VEGFs are very good for health. It causes the apoptotic damage to the photoreceptor and RP. So you should give each anti-VEGF based on each OCT which you do. The OCT has to be done on each follow-up of the patient. Yeah. Check the vision and correlate with the morphology. The morphology has to be seen. You have to see the outer ellipsoid band, everything, plus the inner segment for biomarkers.
Off late, I've been more doing that becomes my second, before even steroid. Nowadays, what sir is telling, I've been more doing ICG guided laser. Okay. That really works in non-response.
But ICG has no role in diabetic retinopathy.
I will tell you, sir. So if you look at some of these, do a ICG, there will be some microorganism which you will pick up. These are fibrin filled, which don't.
That the fluorescein will pick up.
No, that sometimes doesn't pick, because the fibrin, it will not be seen on fluorescein angiogram.
But sir, ICG only shows us the choroidal vasculature.
No, it picks up, sir. You have to just see, because this all I started last ARVO. There was an Israeli.
Can we see some images?
You have some images?
Yeah, I have. I'm actually presenting it tomorrow, the meeting.
Okay.
So they were very bad edemas with thing that works pretty well with the ICG guided. So that's again coming back of laser in our treatment.